For mechanical factors or factors for the implants, we have the heavy occlusal forces, the abutment in traumatic occlusion, and improper selection, design, and placement. With heavy occlusal forces due to excessive biomechanical influence, this may lead to high stress or microfractures in the coronal bone to implant contact, and thus this would result to loss of osseointegration around the neck of the implant. For iatrogenic factors or factors caused by the dentist, it includes traumatic surgical techniques, lack of primary stability, and premature loading during healing period. For clinical features, it includes the clinical signs of inflammation, color change, shiny reddish, bleeding upon gentle probing. We also have the pus formation or suppuration, which will always be a sign of infection with active tissue destructive process taking place. And usually, periimplantitis yields some pus formation upon provocation by pressing on the mucosal tissues, while mucositis lesions may not, and that is one of the difference of it. Another clinical feature is that pocket formation or increasing in probing depth. We also have recession of mucosal margin and mobility. With the tooth mobility being mentioned, you can see the radiographic feature of bone destruction or loss beyond remodeling, and this is seen in the shape of crater as pointed in the arrow. For histopathologic feature, we have the peri-implant lesion extending apical of the junctional epithelium. Not only that, just like in the periodontitis, the connective tissue adjacent to the pocket epithelium is infiltrated by the presence of large inflammatory cells like macrophages, lymphocytes, and plasma cells. Now, this is supported with the case study of Sons et al., wherein they analyzed the soft tissue biopsies from 6 patients with periimplantitis and reported that 65% of the connective tissue portion was occupied by an inflammatory cell infiltrate. Other than that, there are also numerous polymorphonuclear cells, which is supported by the case study of Berglund et al. 2003, where numerous polymorphonuclear cells were present in the human periimplantitis lesions. And such cells occur not only in the pocket epithelium and associated areas of the lesion, but also in perivascular compartments distant from the implant surface. In addition, the case study of Berglund et al. In 2003 is actually in agreement with the observation in the case study of Hutlin et al. In 2002, wherein the elastase marker indicating the PMN cells was found in a larger number of cells in the central portions of the infiltrate. What does this mean? It indicates a high PMN cell activity at sites with periimplantitis. Other than the presence of large inflammatory cells and PMN cells, we also have large numbers of neutrophils, absence of epithelial lining between the lesion and biofilm, and the presence of osteoclasts. Additionally, expression of pro-inflammatory mediators similar to those expressed by periodontitis is also included. We have the interleukin-1 beta, 6, 8, 10, and 17. We also have the tumor necrosis factor alpha, and we also have the mediators of osteolysis, which are the rank and the rankle. And lastly, we also have the matrix metalloproteinase 8 and 9. Next, we have the classification. So the first classification is based on Jovanovic and Klinge in 1990 and Spiekerman in 1991. So on the basis of clinical status of peri-implant bone and required therapy, we have 4 classifications, wherein class 1 indicates of a slight horizontal bone loss with minimal peri-implant defect. For class 2, moderate horizontal bone loss with isolated vertical defect, while for class 3, moderate to advanced horizontal bone loss with broad circular bony defect. And lastly, for class 4, advanced horizontal bone loss with broad circumferential vertical defect as well as loss of oral or vestibular bony wall. So in summary, class 1, slight horizontal bone loss, minimal peri-implant defect. Class 2, moderate horizontal bone loss, isolated vertical defect, while for Class 3, moderate to advanced horizontal bone loss with broad circular bony defect, while for Class 4, this is more advanced and circumferential vertical defect. Another classification is based on Forum and Rosen in 2012, in which this is more of the peri-implant severity classification, in which we have the mild, moderate, and severe. Another classification is based on Forum and Rosen 2012, in which it talks about the severity of the peri-implantitis. We have the mild, the moderate, and the severe. All of them have the presence of bleeding and purulent upon gentle probing. The difference is the pocket depth and the bone loss, in which the pocket depth for mild it's greater than or equal to 4 mm, while for moderate it's greater or equal to 6 mm, while for severe greater or equal to 8 mm. For bone loss, while it progresses from less than 25% to between 25 to 50%, and for severe, it's greater than 50% of the implant length. Another type of periimplantitis is the retrograde periimplantitis, in which there's an infection at the apex of an implant tip in the bone, and we have to understand that persistent periapical infection plays in the development of retrograde periimplantitis. And this is actually a rare case and usually occurs soon after implant placement, supposedly within first to 3 weeks, and under circumstances where complications arise during implant placement, such as, for example, overheating of bone during preparation of the implant osteotomy, or placement of the implant too close to the adjacent tooth, or altering of the blood supply of the adjacent tooth during implant surgery, and the implant itself may result in the devitalization of adjacent tooth and subsequent development of periimplantitis. Other than the implant placement issue, it is also said that the persistence of endodontic bacteria and inflammatory cells, which is said to be more common, facilitates the development of retrograde periimplantitis. Thus, it suggested that the origin of the retrograde periimplantitis is due to chronic tooth abscess and implant placement in the freshly extracted socket. Retrograde periimplantitis often features with intense throbbing pain that is associated by swelling, pain, tenderness, and sinus tract formation. For its treatment, it is not suitable for strong antibiotic therapy, therefore surgical decontamination is quite necessary. For the diagnosis for periimplantitis, we have the probing, the radiograph, and the microbial monitoring. For the probing, if it's greater than 4 mm, then it indicates periimplantitis. And if there's a presence of bleeding after the penetration of periodontal probe into the peri-implant sulcus or pocket using gentle force, then this is also a good clinical parameter for identifying periimplantitis. And the presence also of suppuration or pus formation upon probing is also included. For the radiograph, it is said that the periapical radiograph is better than the panoramic radiograph, since we're trying to diagnose the peri-implant bone status as well as the marginal bone level. Under radiograph, you can also see a shape of crater defect. Lastly, for microbial monitoring, it evaluates the peri-implant health and condition of the microbial composition of periimplantitis. For the diagnosis, we all know periodontitis, despite the similarities in both the bacterial etiology and the immune response component between the periodontitis and the periimplantitis, the biggest factor or the difference between the two is that in periimplantitis, the periodontal ligament is not involved and it progresses at a faster rate with more pronounced bone loss compared to periodontitis. Now, this may be attributed to differences in the orientation and insertion of collagen fibers around the teeth compared to those around dental implants. And again, this is supported with a study in the dog models by Lin Hay, in which the pattern of spread of inflammation was different in periodontal and peri-implant tissues. Last but not the least, we have the management of periimplantitis, which includes the occlusal therapy, the non-surgical therapy, and the surgical therapy. For occlusal therapy, it includes analysis of the prosthesis fit, the change in prosthesis design, and improvement of implant number, position, and occlusal equilibration. While for non-surgical therapy, we use debridement with antiseptic oral rinses. Specifically, we do a subgingival irrigation of all peri-implant pocket with 0.12% chlorhexidine for 10 days consecutively. Under the non-surgical therapy, they usually do local removal of plaque with plastic instruments and polishing of all accessible surfaces with pumice, and improvement of oral hygiene, and they also do surface debridement with the use of lasers, since in a clinical study it evaluated the effectiveness of laser therapy for periimplantitis, and the result indicated that the laser therapy resulted in a significant reduction in the bacteria counts. And among the lasers applied for surface decontamination, the erbium YAG laser is actually used widely by clinicians because it's considered to possess good properties for calculus removal, degranulation, and surface decontamination. So how does it work? The erbium laser light is absorbed by the water in your skin cells, and then it causes this instantaneous vaporization of the cell, and as the laser light passed over the skin, a part of the tissue is actually removed at a time. Now, to support the idea that this type of laser is better than others, if you base it on to Newman and Carranza's study, in which there's a higher clinical attachment gain or bone implant contact with the laser therapy having a high degree of re-osseointegration by 44.8% as compared with ultrasonic, which is 8.7%, and the plastic curette and metronidazole gel debridement, which is only 14.8%. For surgical therapy, it includes the re-establishment of the osseointegration, or in much simpler term, it's the formation of new bone in contact with the previously contaminated titanium surface. Now, the problem with this is that re-osseointegration to a once contaminated implant surface is actually difficult, and the outcome of such regenerative procedures is difficult to predict. Surgical procedures are used to treat bone defects around teeth, and this includes, first, open flap debridement, which is more effective in the treatment of periimplantitis than closed debridement. Second, we have the resective therapy, in which this is indicated with the presence of shallow, which is less than 3 mm, or 1 to 2 wall defects. And this is also indicated for implants confined in non-aesthetic sites. And lastly, we have the regenerative therapy, in which this is indicated for those with presence of 3-wall or circumferential defects or with crater defects, and this is done with an attempt to rebuild or regenerate lost peri-implant tissues. With these methods that I have discussed to you under surgical procedures, it's been reported that they have better results when compared with surgical debridement and surface decontamination alone. And generally speaking, for surgical therapy of periimplantitis, it's considered to be superior to non-surgical instrumentation because it provides better access to perform a complete removal of all granulation tissue from the defect area and decontamination of the exposed implant surfaces. However, you still have to include non-surgical therapy, since in all cases, non-surgical therapy is to be performed prior to surgical therapy to assess the healing response, the patient's compliance, and oral hygiene. You still have to include the occlusal therapy, since this is to be done if the prosthesis design hinders the capability of the patient for a good oral hygiene and influences the progression of periimplantitis. Basically speaking, the occlusal therapy and the non-surgical therapy and surgical therapy are all in one.